to invite our first speaker, Dr. Balvinder Rana, who is a well-known figure in foot and ankle surgery in India. He is ex-president of Indian Foot and Ankle Society, and he works as a senior consultant in Max Hospital in Delhi, in Gurgaon. And we all know him very well. And he's a figure, Pilon fractures. I think nobody else can actually tell us more about Pilon fractures than him. So I'd like to invite Dr. Balvinder to give his talk on Pilon fractures. Thank you.
Hello, Maninder. Thank you for inviting me. And I thank IFA, especially the president, Dr. Mahendra, and Secretary Shantanu for creating these programs and starting with the Pilon fractures. So, Pilon fractures, I'm going to give you an overview and a detailed discussion on how to manage them operatively. So it's going to be a bit of a longish talk, so you can sit back and relax and stretch. So we need to be able to analyze the Pilon fracture as not only a fracture, but a soft tissue injury, and be able to adequately manage the soft tissue injury. We should be able to analyze the scans, the CT scans of a Pilon fracture to decide which approach is best for definitive treatment. And we should be able to execute that definitive plan for sure for a good outcome. Now, some of the situations can be complex right from the start. I always say that every fracture can be classified just basically into two types. It can be complex from the start, something like this. So this is the situation which is complex right from the start. There is nothing much you can do about it. You can change a bit of things, but not many. However, on the other hand, there can be situations, fractures and real life situations where the situation is not that bad. But if you do not have the proper knowledge and equipment and the techniques to take care of these things properly, then we can end up in a difficult scenario. So look at the two X-rays on top. Not that bad. I would not say this is a bad Pilon fracture. Look at the articular surface is very well maintained. Just a bit of step there. Metaphyseal comminution, yes, but it was converted into this type of an injury by a surgeon. So this is an iatrogenic complexity, eminently avoidable situation by sticking and adhering to the principles that we know we should follow in these kind of fractures. So you name it, an articular comminution. In a Pilon fracture, you name a fracture complication and you have it in Pilon to the extent that it can disable the patient's life and even lead to amputation. You can have bad soft tissue injuries in this area. The skin circulation is bad. You can have skin necrosis, infections. You can have severe articular comminutions, which make joint salvage almost impossible, leading to arthritis, stiffness, malunions, delayed unions, and obviously in some series in earlier years, reported an amputation rate as high as 30%. But now, fortunately, we know the tricks and the techniques of the trade, and we know that how we can avoid bad complications in these type of fractures. Going back to the Pilon fracture, metaphyseal comminution, yes, a bit of an articular injury on the medial side, and in the center of the joint, there is an articular step. Now, this is not the patient's picture. This is a representative picture, how we believe the leg would have looked on that day. A lot of soft tissue injury must have been there. I did not see this patient on day one, actually. So if we have that kind of a picture, then what should be done first? Should we think about a plating? Should we think about a plating with tibia and fibula? Should we do a CT scan first, or should we do a joint spanning external fixation, plus minus maybe open, reduce the fibula and wait it out? What should be the option in these patients? I would say that third is the option. We should not be operating them on day one. We should not be thinking about a CAT scan on day one. Our priority should be soft tissue and soft tissues alone on day one in this kind of fractures. So a joint spanning external fixation should be the protocol, but that is not what was done for this patient. On day one, the operating surgeon did an open reduction internal fixation of the fibula by a lateral approach, did an open reduction of internal fixation by minimally invasive so-called approaches on the distal tibia, and he tried to fix the articular fractures with that kind of screw. anterior to posterior, one screw from the medial valvulus, and one K wire. And somehow or the other, he thought that the patient had compartment syndrome and left a large anterolateral wound on the leg open on this side. So I don't know why I'm getting this on the top. I'm seeing a lot of options. Um, am I clearly visible and audible, Maninda? Hello.
Yes, sir, you are. Everything is
Yes,
fine.
we can hear you, Balvinder. Please carry on.
Everything is in order. My screen is clear because I'm seeing a lot of captions on my screen, which generally doesn't happen in a Zoom meeting.
We can
Can you see these
see nothing
options on
clear.
the top?
We
Everything
can
is
see
okay,
everything
sir.
clearly. We can't see anything
Okay,
optional.
fine. Okay, I'll continue then. So
Yeah.
this side is the heel you see, and this is the anterolateral leg, a large wound which was left open, skin grafted later on, and small wounds on the anterior side. So this fracture has been converted into this injury at 6 weeks when the patient presented to us, and this is now a nightmare. So basically, the treatment options that we have for Pilon fractures are four types: non-operative treatment. Second is proper open reduction internal fixation, which can be a MIPO or MIPO, minimally invasive internal fixation, or proper open reduction internal fixation, mostly a two-stage process. Third option is an external fixator, which can be combined with minimally invasive internal fixations. Or the fourth option is a primary fusion. So we have to be aware of applying these treatment protocols, these four, to individual patients who deserve this. So not every patient will be fit for MIPO, and not every patient will be fit for an external fixator, and very few will need a primary fusion. So we should be aware of which patients need what. Talking about the mechanism of injury, if we want to decide about what kind of treatment the patient needs, then it starts from eliciting an exact mechanism of injury. Classically, we see two types of fractures. One is a high energy motor vehicle accident, which is a significant soft tissue injury associated with it. And in these type of cases, we want to do a two-stage treatment protocol. The second is a low energy twisting injury, which has a good soft tissue envelope, and this is amenable to an early fixation. So we should consider pilon fracture is that this is a bone break in an injured soft tissue envelope. So primary treatment has to be directed at the soft tissue coverage. So the early management only concerns the soft tissue management. So there is a and we want the soft tissues to. Am I audible again? Sorry,
Yes,
did
we can
I?
hear you. Yes, we can hear you.
Yes, you are audible, sir.
In between their hiccups. In between their hiccups.
Okay, it's a network, I think, right? Okay, so
Go ahead. Yeah.
so two-staged treatment protocol involves stage one, where we do a joint spanning external fixation when the soft tissues are not good. In this kind of situation, when we do this, we have to consider putting the tibial pins as high as possible in the proximal to the fracture and calcaneal pin posteriorly in the calcaneal tuberosity, creating a delta kind of a frame. And with that, we may or may not combine fibular open reduction and internal fixation in stage one, depending on a number of factors. If the fibula is transverse, easily reducible, and we are going to be the surgeon who is going to do the definitive surgery. So then fibula open reduction internal fixation can be done. Otherwise, there is no harm in leaving the fibula alone and just doing an external fixator on stage one. Now that is the first stage, and then we do a scan of these patients, CT scan, after the external fixation has been done, because that defines the fracture much more clearly. And the third stage is then the plan. That is the treatment which we call as span, scan, and plan. So CT scan is done after the fixator has been applied, and that CT scan is studied in detail to decide about definitive treatment option, and then that treatment option is executed after the soft tissues have healed in stage one. So CT scan will tell us what approach, which plate, which surface to be plated, and what is the best treatment option. Here is an example: comminuted fracture, metaphysis extending onto the articular surface. This kind of soft tissue picture is not amenable to early reduction, early internal fixation. So patient has to be put on a joint spanning external fixator. Calcaneal pin is distal in the tuberosity, and the tibial pins are high up away from the fracture site so that they do not come in way of your definitive approach. And once the soft tissues have healed, then these patients have taken up for definitive fixation. So the key points we have built on, first is look for a soft tissue injury. And whenever there is a soft tissue injury in a high energy motor vehicle accident fracture type 1 injury, then we apply a joint spanning external fixator, and then we do a CT scan and then analyze the CT scan to classify these fractures. That is the second stage of treatment. So this is the classification that we should be grossly aware of. Type A, B, and C. A is extra-articular from A1 to A3 with increasing complexity, increasing severity. Type B is partial articular, where one joint surface is fractured and with increasing severity of comminution, B1 to B3. And type C, when there is a complete articular comminution and metaphyseal extension of the fracture, again C1 to C3 progressing with increasing amount of comminution in the metaphyseal and articular areas. So it's a very simple classification, but that gives us a very basic idea, a very informative idea to decide about the best treatment approach for these patients. So we have reached the stage of having applied an external fixator, having done a CT scan, and the third step is then doing the definitive fixation. Whether we should be doing a minimally invasive approach or an open reduction internal fixation depends upon the type of fracture. So there are only two types of fractures which are ideally suited for the MIPO technique. We just discussed the AO classification. So in the AO classification, the extra-articular AO A type, that is A1 to A3, which are also nailed, can be nailed, but it's a difficult nailing, are the ideal fractures for MIPO technique. So this fracture can be extending into the joint, like in 41 in AO classification C1. So simple intra-articular extension with a metaphyseal fracture is also an ideal situation for a minimally invasive plate osteosynthesis. Please consider that all of the other AO types are not good candidates for a minimally invasive approach. If we try to do a minimally invasive approach in a complex articular pilon fracture where there is a lot of comminution in the joint and impaction in the area of the articular surface, and we cannot address that by way of MIPO, so MIPO will not succeed in those kind of patients. But if we think that our fracture now, based on CT scan, classifies as a AO A type or C1 type, then we can decide about a percutaneous technique. But then we have to consider that it is a reduction which has to be achieved before application of the plate most of the times. And we have to follow the principles of length, alignment, and rotation maintenance for these kind of fractures. And there are various techniques which can be used to achieve the reduction, like percutaneous clamps, distractors, or plate reduction tools. Here are some examples of percutaneous application of a reduction clamp, and then an interfragmentary screw, and finally a bridge plate has been used percutaneously to stabilize these fractures. So now we have built on our key points. First, we looked at the soft tissue injury. We did a joint spanning external fixator. Then we obtained a CT scan. Then we decided to do a definitive fixation, and our fracture was type A and C1. Then we can do a MIPO plating using the principles of length, alignment, and rotation. But if our fracture does not fall into these categories, then we have to do an proper open reduction and internal fixation for these fractures. And then the available open approaches, we all know, are 4 anterior approaches and 2 posterior approaches: anteromedial, modified anteromedial, rarely used, anterolateral, straight anterior, and 2 posterior approaches: posterolateral and posterior-medial approach. So now, if our fracture is not amenable to MIPO and we want to do an open reduction, then there are 3 questions that we need to decide, we need to answer to decide which approach has to be used. And then we have to execute. Then the second step is to execute that open approach meticulously to avoid soft tissue complications and get good results. The first question, that is, decide which approach to use, whether we want to use an anteromedial or anterolateral or straight anterior or a posterior approach. You need to look at 3 things, basically. 3 questions have to be answered. The first question is a biomechanical question. Which surface will give you the best stability for that fracture? Now that is answered by the fibular fracture type. Where is the fibular fracture dislocation or displacement? And where is the tensile or the compression failure side of the tibia? And the question number 2 and 3, which help us to decide which surface is to be plated or which approach has to be taken. There are more biological, like where are the major fracture fragments, where are the areas of intra-articular comminutions and impactions which we need to elevate. So an approach has to be used which takes us directly to these areas of major fragments intra-articular. So the CT scans for this purpose have to be studied meticulously to what is the approach which will take us directly to that area of the joint. So these three, and the third is obviously the soft tissue connection. Soft tissue conditions will also dictate to a large extent if the soft tissues are not good, then we have to modify some of these approaches. So coming back to the question one, fibular fracture type, and which is the tension and the compression failure side of the tibia. So a varus failure, that is a medial displacement of the distal fibula or a medial displacement of the distal tibial fracture fragment is a varus failure. So this needs to be supported on the medial side because the medial side is the compression failure side of the tibia. So the compression failure side of the tibia needs to be plated and not the tension failure side. So in a varus failure, it is the medial plate which is ideally indicated, like in this patient, which we did an anteromedial approach and did an open reduction in the medial distal tibial locking compression plate, and obviously associated with a fibular ORIF also. Another example of a compression failure or a medial side failure is compression failure in a varus failure. Fibula is displaced into varus. There is a tibia failure in varus. So this surface is the surface which is under compression forces, and this is where the plate needs to support the fracture. So again, the same principles, medial side plating. So that is how we decide about the surface of the plate, but the surface of the bone which needs to be plated. But at the same time, we need to look at not only the compression and tension failure size of the tibia, we need to look at where are the major fracture fragments and where are the intra-articular areas of comminution and what are the soft tissue conditions. For that, we need to look at the CT scans to define where are the major fracture planes, comminutions, intra-articular impactions. And there is a study by Topless, which is divided basically broadly the Pilon fractures into two families. The coronal families, when the major fracture line is in the coronal plane of the body, is more amenable to an anterolateral plate, while a sagittal fracture line, where the major fracture line is in the sagittal plane, then it is more amenable to possibly a medial plate or a lateral plate. But the anterior plate comes into focus more if you have a coronal fracture at the distal tibial metaphysis or plafond. So they have defined there are 6 fragments which can be defined, and based on these fracture fragments, where they are located, where what is the size of the fragments, which is the most major fragment. Depending on these factors, we decide what is the best approach. Now there is a funda of a functional diastasis in this kind of fracture. So you can have a small fragment attached to the lateral fibula, to the fibula on this side at the tibiofibular joint. So the syndesmosis actually is intact, but because of the location of the tibial fracture being close to the syndesmosis here, a chip fracture can remain attached to the fibula. That creates a functional diastasis, and many times we tend to ignore this, and that is a cause of extremely poor results because that fragment will not heal properly and will become a functional diastasis, leading to divarication and the fibula. So we need to look at that. So now we have come to points 5 and 6. We are building upon our treatment. So we do an open reduction internal fixation proper when our fracture is not amenable to MIPO. That is, we have a comminuted fracture. We need to go in and reduce the joint fragments and put a plate in. So for that purpose, we need to read the radiology carefully and decide the correct surgical approach. Once you've decided the approach based on these factors that we've just discussed, then the first thing that we have to decide is to be gentle in the operation theater. We as orthopedic surgeons, we are used to that kind of surgeries, and distal tibial pilon fractures are not amenable to aggressive techniques. It's a tissue. The tissue in that area will not forgive us if we are harsh on those tissues. There is an example of a severely comminuted distal tibial fracture. We can see that there is a die punch fragment there inside. So if you look at it carefully, it seems that there is a large anterior fragment there is a large posterior fragment there, and the center part of the joint is impacted. So that is an area which we need to reduce. We need to go in and put this fragment down back and then fix it. So the principles are that we need to retain parts of the external fixator when we are taking these patients to theater. We do not remove the entire external fixator. Some of the pins and rods which are not in the approach can be retained, and only then we'll be able to do justice to these patients. So that is the first step, is to distract the joint. Now we are going into the techniques of upper reduction and internal fixation. Here we are putting a shank pin into the neck of the talus after having exposed the distal tibia. Now, unless we distract these fractures, we are not able to look at the entire articular surface. And once we have distracted them, then and then only we are able to look at the joint surface and recreate. So that was the fracture that we just saw in the X-ray. And unless we distract it, we'll not be able to see the impacted surface in the center. We have retracted the anterior fragment laterally, and we have gone in and we are looking at the joint surface, and we can see the center of the joint is depressed. And these are the areas which needs to be put back, and the surface has to be built on this fragment. So this is how we brought down the central fragment after distracting. We closed the anterior fragment with a clamp and then put a K-wire stabilizing the entire construct, and then went on to put a plate on top of it. But then these are situations that are amenable to open reduction. We can go in with high expectations, and we can come out in reality not being able to reconstruct the joint. So there is definitely a role of primary orthodesis. There have been now reports in the literature of results of primary ankle orthodesis in severely comminuted pilon fractures. Some of the studies have now shown that primary ankle orthodesis in these kind of situations where we believe that the joint is union, and it is a comparable functional outcomes to open reduction, internal fixation, and type C fractures. So there is definitely an option of primary orthodesis, but you need a lot of experience to fuse a joint which is badly shattered. So it's a surgery which is not to be taken lightly. So then the key points finally: look for soft tissue injury, apply a joint spanning external fixation in case of soft tissue injury. After that, obtain a CT scan, classify the fracture. If the fracture is type A or C1 fracture, then we can do a MIPO by achieving length alignment rotation. If it is different type of a fracture, severely comminuted, then we need to go in and do an open reduction internal fixation after the soft tissues have settled down. For that purpose, we need to study the CT scans carefully to decide which surgical approach is required to be done. And during surgery, we should retain parts of the external fixator and then distract the ankle joint by putting a pin in the neck of the talus and connecting that pin to the proximal tibial pins, distracting the joints. And then we have to find the areas of comminution and find a constant fragment on which to build our reduction. And finally, we did not mention it earlier, we need to bone graft the metaphyseal defects as we do from the proximal tibia. I have omitted the treatment by external fixation. There is a school of thought that severely covered fractures can be managed by ring fixators. I'm not on that school, so I've omitted it. If you are fond of doing external fixator, then you can consider that. So thank you very much. Over to Maninder.
Thank you, Balvinder. That was an excellent talk on the whole aspects of how we manage pilon fractures. And I'm sure lots of people have questions to ask you. But first, if we have, I think we'll move on to Dr.